Hi, I am Dr. Selvaraj, Professor of Surgery at Manipal University College, Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing their surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. In this episode, I am going to talk about obstructive jaundice, a problem oriented approach. I've already made videos on obstructive jaundice, but this video is a single video where I will be discussing five important causes of obstructive jaundice. So you have to watch, after watching all those videos, you should also watch this obstructive jaundice video where it is problem based approach. So what is the learning objective? So after watching this presentation, all of you should be able to define what is obstructive jaundice and should realize the importance of obstructive jaundice. You should also know the anatomy of the biliary system and the various causes of obstructive jaundice. I will be discussing elaborately about five causes of obstructive jaundice, namely choledocholithiasis, biliary atresia, carcinoma, head of the pancreas, periampullary carcinoma, cholangiocarcinoma, and finally I will be showing a tabular column which is a quick recap. So, what is the definition? Obstructive jaundice is a medical condition characterized by obstruction of normal bile flow from the liver to the small intestine, leading to the accumulation of bilirubin in the bloodstream. So, if we are not going to treat these cases, obstructive jaundice, eventually, this will produce progressive liver damage and ultimately liver failure. In order to avoid these complications, we have to make timely diagnosis and immediate effective intervention to avoid these complications. This obstructive jaundice not only treated by surgeons, this is treated by a multidisciplinary team consisting of a gastroenterologist, hepatologist, oncological surgeon, the radiation oncologist, and the medical oncologist to ensure a comprehensive care to these patients. So, this is the anatomy of the biliary system. I want to concentrate only on the extrahepatic biliary system, which consists of right and left hepatic ducts joined together, forming common hepatic duct, which will be joined by the cystic duct. Then, this is the common bile duct, which is also again will be joined by pancreatic duct, forming a common channel, and eventually this will open in the second part of the duodenum, that is the sphincter of Oddi and the ampulla of Vater. This is ampulla of the Vater. And this is the gallbladder, which consists of fundus, body, neck, and in the neck you can see a redundant portion called Hartmann's pouch or the infundibulum of the gallbladder. So, what are the various causes of obstructive jaundice? We can divide it into intraluminal causes, mural causes, and extramural causes. Coming to the intramural causes, The commonest cause is choledocholithiasis or presence of gallstone in the common bile duct. Or it could be presence of one of the parasites, either Cholangiocarcinoma sinensis or Ascariasis. The mural causes are biliary atresia, that is atretic biliary ducts, which is a congenital problem, or it could be a malignant strictures like cholangiocarcinoma or benign strictures like sclerosing cholangitis. Coming to the extramural causes, that is, the number one is carcinoma, head of the pancreas, periampullary carcinoma, and portal lymph node, because these lymph nodes are secondary lymph node because of the primary GI tumors. This could be stomach carcinoma or colon carcinoma or even rectal carcinoma is primary. So these primaries will produce secondary big lymph nodes in the portohepatis, which will obstruct the extrahepatic biliary radicals, and patient will go for obstructive jaundice. All these causes here in this picture, you are you are seeing it in a picture form. So this is CA, head of the pancreas, periampullary carcinoma, cholangiocarcinoma. This is the choledocholithiasis. This is parasite, either Ascariasis or Cholangiocarcinoma sinensis. This is stricture, benign stricture. So everything is shown here. Choledocholithiasis is the commonest cause for obstructive jaundice. So coming to the etiopathogenesis of choledocholithiasis, the stone could be primary stone in 5% of the patient, whereas in 95% it is secondary stones. That means stones are developing in the gallbladder and then it is coming to the common bile duct through cystic duct. Additional stones may be there in gallbladder. Stones may pass into the duodenum asymptomatically, that is, without any problem. Biliary colic occurs when the ducts are partially obstructed. Complete obstruction of the duct will cause duct dilatation and jaundice. Eventually, this results in both ascending and then suppurative cholangitis. Stone in ampulla of Vater can cause gallstone pancreatitis. Coming to the clinical features or signs and symptoms, patient, the choledocholithiasis patient will present with right upper quadrant pain, nausea and vomiting. Patient will be also having episodic or intermittent jaundice. If it is choledocholithiasis, patient will be having only right upper quadrant pain and jaundice. Of course, patient is having obstructive jaundice, so they will have high color urine and pale color stool. If patient is having this jaundice for some time, okay, the infection will superadded infection or secondary infection will happen to the stagnant bile, and patient is also going to have fever. So right upper quadrant pain, jaundice and fever is called Chagas triad, which is characteristic of ascending cholangitis. Even now, if we are not going to treat the patient will go for two more features, that is altered mental status and hypertension. Now this is called Raynaud's pentad, and also this is suppurative cholangitis, which is an acute surgical emergency. So gallbladder in these cases, in choledocholithiasis, is not palpable. This is your Courvoisier's law, which says in a jaundice patient, if gallbladder is palpably enlarged, that is not due to gallstone, because if it is because of gallstone, these stones in the CBD usually develop in the gallbladder only. So gallbladder might have undergone plenty of, infection and several episodes of infection and inflammation. In that process, the gallbladder might have become already fibrous, so it cannot get distended even though there is an obstruction to the flow of the bile in CBD. Coming to the diagnostic workup, you have to do LFT where the total bilirubin is increased. Direct conjugated bilirubin usually will be more than the indirect unconjugated bilirubin. Both ALP and GGT both are elevated if it is liver or gallbladder pathology. Alkaline phosphatase is also increased in bony pathology, in pregnant women, and in pediatric population. So in order to differentiate the other causes for increase of alkaline phosphatase, we should do GGT also along with ALP. If both are increased, that means the pathology is only because of hepatobiliary pathology. If we do ultrasound of the hepatobiliary system, we can see only the gallstone. We cannot see the CBD stones, or we cannot pick up choledocholithiasis, but the sonologist can tell whether the CBD is dilated or not. If CBD is dilated, then we have to do investigations like MRCP or CT scan to find out stone in the biliary duct. But the gold standard investigation is ERCP, which is not only diagnostic but therapeutic as well, where by doing ERCP, we can also extract the stone from the biliary ducts. You can also do endoscopic ultrasound and find out stone in the biliary ducts. In case of ascending or suppurative cholangitis, we should send blood for culture and sensitivity. Coming to the treatment, okay, I told ERCP is therapeutic also. So do ERCP, do a diagnostic workup and find out the stones. Then in that sitting itself, we can do a sphincterotomy and do the stone extraction either with Damia basket or balloon swab. But this ERCP stone extraction should be followed by either an open or lap cholecystectomy. In ERCP failure cases, we can do what is called open choledocholithotomy, where you have to open the abdomen, laparotomy, and then open the common bile duct and remove these stones using what is called Desjardins forceps. If patient is having only ascending cholangitis, this can still be treated with broad spectrum high antibiotics. If patient is already gone to suppurative cholangitis, the pus, the infected bile will be full of pus. So this can be drained either by nasobiliary drainage using a ERCP, putting a stent in the CBD, or we can do what is called percutaneous intrahepatic biliary drain, where you can poke the liver through the skin with a long and thin needle, then poke the liver also, and then poke the intrahepatic biliary radicals, which are dilated. The moment you are poking these intrahepatic biliary radicals, the infected bile will gush out of these intrahepatic biliary radicals. So this is the ERCP where you are seeing the stone here. Two stones you are seeing. This is the endoscope. This is both diagnostic as well as therapeutic. Whereas here you are seeing a MRCP instrument where you need not use any dye to take this picture. But in both the pictures, apart from seeing these shadows, the filling defects. You can also make out dilated extrahepatic and intrahepatic biliary radicals in both the pictures. And this is the endoscopic ultrasound. This also you can do and pick up the stone here. This is the CBD. See here you are seeing the stone. The CBD proximal to the stone is dilated. The CBD distal to the stone is very narrow. And this is ERCP stone extraction. Here you are seeing a sphincterotome, a bowl-like instrument with a string. So you have to introduce it here, and through this string you have to pass current, and you have to cut this sphincter at 12 o'clock position, because this is avascular area. And another reason why you have to do sphincterotomy, because this sphincter is always in a closed state continuously. If you want to put either this Damia basket or this balloon inside the CBD, then you have to cut the sphincter. Then only you will be able to put this Damia basket inside. That is what you are seeing here. Damia basket. With the Damia basket, you have caught that one stone and you have removed it. So you can, whatever amount of the stone is there, you can one by one, you can catch them and you can remove it. If you use balloon, then you have to put the balloon when it is deflated, put it proximal to the first, the stone in the CBD. Then you have to inflate the balloon, and then just you have to, pull it down. So this is what is called balloon swipe. This also you can do to remove the CBD stones. The second condition is biliary atresia. This is a congenital obliteration of biliary system, both extra and intrahepatic. The exact cause is not known. Because of back pressure, there is portal tract edema, bile duct proliferation, and portal and pericanalicular inflammation, and hepatocyte injury, and eventually cirrhosis of the liver. Coming to the clinical features, the baby will be having progressively increasing jaundice from day 1 onwards, throughout the neonatal period and during the infancy. Baby will have high color urine, pale color stool, that is acholic stool. Itching also will be there. Hepatosplenomegaly may be there. Features of liver failure in very late cases. The diagnostic workup, again LFT you can do, where the total serum bilirubin will be elevated with direct more than the indirect bilirubin. Both ALP and GGT are elevated, but the investigation of choice is hepatobiliary scintigraphy, or this is also known as HIDA scan. This will show uptake of the radioisotope into the liver. Liver you can see, but the radioisotope won't get excreted into the biliary, into the biliary ducts, because these ducts are blocked. When you are doing, you can also do liver biopsy to rule out neonatal hepatitis from the biliary atresia. This can be done percutaneously or part of an exploration along with intra-op cholangiography. So that also, even though the hepatobiliary scintigraphy is positive, it is better to do an intraoperative cholangiogram also, because some of these cases may not be biliary atresia. It could be a case of inspissated bile syndrome, where the bile will be very thickened. If you are going to do the intra-op cholangiogram, these thick bile will be solved, it will dissolved by this dye which we are injecting, and patient will be all right. It is Actually, it is not a case of biliary atresia. So, intracholangiogram will be therapeutic in those cases. Coming to the treatment of biliary atresia, all the extrahepatic atretic bile ducts should be excised, and then you have to dissect these extrahepatic biliary radicals up to the hilum of the liver. There will be a fibrous cone, triangular cone will be there, that you have to bisect or cut it as close to the liver as possible, so that you can see microscopic, very small ductules which will secrete, which will be secreting the bile. So then you have to divide the jejunum 40 centimeter from the DJ flexure and take the distal segment through the retrocolic route up to the porta hepatis and do an anastomosis with the porta hepatis area where you have dissected the small biliary ductules. This is called portoenterostomy or Kasai's procedure. The divided proximal limb of the jejunum, you can anastomose with the jejunum. Uh, you can anastomose side to end. End to side, you can do the anastomosis. This is jejunostomy. So bile then drains from the liver via the small hepatic biliary ductules. Liver transplantation for those who do not develop bile flow, or the babies who ultimately develop fibrosis of the intrahepatic biliary ductules. So eventually, only 50% of these babies, after even doing a successful Kasai's operation, which should be done before the baby is of 2 years of old. Even if you are doing a successful surgery at the correct time, only 50% of these Kasais will be successful. Another 50%, there won't be any biliary secretion, and eventually these babies need liver transplant only. So here you are seeing the varieties of, the biliary atresia. Here you are seeing the whole gallbladder, cystic duct, and the right and left hepatic duct and the common hepatic duct are atretic, whereas the distal CBD is pattern. Here only the common hepatic duct is atretic. This is 2A. 2B, okay, the proximal part is pattern, right and left. The distal parts are atretic. Here everything is atretic. This is type 3, this has got worst prognosis. Okay, here you are seeing a late case with cirrhosis of the liver, and in very advanced case, you can even see these babies with ascites. So you can do an ultrasound. Normally, the portal triad, you can see what is called a Mickey Mouse sign, where you can see the portal vein posteriorly, anteriorly you can see the bile duct and the hepatic artery. Three structures you will see, whereas here portal vein you can see, but anterior to that you will see a triangular cord because it is atretic. Biliary duct you cannot see separately. This is triangular cord sign. This is the HIDA scan. Yeah, this is a radioisotope scan. You are seeing only the liver is uptaking the radioisotope, whereas it is not getting excreted in the biliary radicals, and it is not going to the duodenum and then to the small bowel. So the persistent jaundice, that is the conjugated hyperbilirubinemia, if it is more than 2 weeks in full-term infants and more than 3 weeks in premature babies, you have to do workup rapidly, and you have to do abdominal ultrasound and the isotope scan, HIDA scan, and then you have to do exploratory laparotomy or laparoscopy, do operative cholangiogram also. At that time, you should do liver biopsy also to rule out neonatal hepatitis. Then you have to proceed accordingly. So the next condition is CA, head of the pancreas. The exact cause is not known. Risk factors are cigarette smoking, increased age, chronic pancreatitis, increased saturated fat intake, exposure to non-chlorinated solvents. The genetic risk factors are chronic familial relapsing pancreatitis, familial breast cancer, that is BRCA2, Gardner syndrome, HNPCC, hereditary non-polyposis colorectal cancer, and Purus-Jaghas syndrome. Tumor in the head of the pancreas cause extrinsic compression of the distal CBD, causing obstructive jaundice. Coming to the clinical features, patient will have painless progressive jaundice in contrast to the choledocholithiasis. In choledocholithiasis, the jaundice is painful and intermittent. In CI head of the pancreas, the jaundice is painless and progressive. Of course, the patients will have high color urine, pale color urine with itching, nausea and vomiting, but they also will have loss of weight and loss of appetite. But here, the gallbladder is palpable. This is the Kurvaisius law because the jaundice is not because of gallstone. So you can palpate the gallbladder, which is not tender. So coming to the diagnostic workup, again LFT, total serum bilirubin, is elevated with direct bilirubin more than indirect. Both ALP and GGT are elevated. If you do ERCP in a case of CA head of the pancreas, you can see a classical dual duct sign, which means both the CBD and pancreatic duct are dilated, and you can see a filling defect at the head of the pancreas level, which is because of the extrinsic compression of both these ducts. If you do ultrasound of the abdomen, you can detect only very huge tumors. In CT abdomen, you have to do what is called triple phase CT abdomen. This is sensitive to pick up even small hyperdense lesions, and it is very important for staging purpose also. With EUS guided pancreatic biopsy also you must do to confirm the diagnosis. Coming to the treatment, these tumors can be divided into resectable tumors, borderline tumors, and unresectable tumors, depending upon the stage. If it is early or resectable tumors that means tumor is confined to the pancreas, where you can do what is called Whipple's operation or pancreatoduodenectomy. If it is borderline tumors, that means the tumor is extra pancreatic, but it is just touching the superior mesenteric artery, not encircling it. Still, we can do surgery, but we can do what is called neoadjuvant chemoradiation to downstage the disease or to reduce the size of the tumor, and then you can go for surgery. In case of unresectable tumor, only palliative bypass surgeries are possible, where we can do what is called palliative triple bypass. Open surgery, we can do cholecystojejunostomy and then gastrojejunostomy and jejunojejunostomy. If you are doing it with endoscopy nowadays, okay, this is, if it is biliary obstruction, we can do biliary enteric bypass, that is cholecystojejunostomy. You can put an endoscopic biliary stent placement, or you can using a ERCP or radiographic transhepatic stent placement, that is PTC, that also you can use. In case of gastric outlet obstruction, you can put a gastroenteric bypass, you can do, that is gastrojejunostomy you can do, or you can put endoscopically a duodenal stent. These are all only palliative procedures, not curative procedures. This is a CT scan where you are seeing a tumor, big tumor in the CA, in the head of the pancreas, which has already come out of the pancreas, and this is just touching the superior mesenteric artery. So this is borderline resectability. Whereas here in this picture, you are seeing an endoscope here, and this is a ERCP where you are seeing both the dilated CBD and dilated pancreatic duct. This is the extrinsic compression because of the CA head of the pancreas. This is called dual duct sign. So endoscopic stent you can put by using a ERCP, you can put, this is the stent, or you can do it through the liver, that is percutaneous transhepatic stent also you can put. If you want to put a stent in the duodenum, you can use an upper GI endoscope, you can put this stent in order to avoid gastric outlet obstruction. Because of the tumor here, the duodenum may get compressed. Coming to the periampullary carcinoma, this is a malignant tumor arising in the last centimeter of the common bile duct. It can arise from one of the four epithelial types: the terminal CBD, from duodenal mucosa, pancreatic duct, and ampulla of Vetter. The ampullary adenocarcinomas have two principal histological forms: intestinal and pancreatobiliary. The pancreatico-biliary tumors follow a more aggressive course. Coming to the clinical features, the patients will have painful intermittent jaundice, whereas in choledocholithiasis, also they are having the same painful intermittent jaundice, because these tumors will undergo partial necrosis and will fall off from that duodenum. So there won't be any compression of the CBD. Patient will be relieved of jaundice. Of course, the patient will have high color urine, but the stool is characteristically silver color. This is very important because of mixing of blood oozing from the tumor with A. colic or clay color stool. That is the cause for this classical silver color stool. Patient also may have itching, nausea and vomiting, loss of weight and loss of appetite. Gallbladder is palpable. That is your Courvoisier's law, because jaundice is not because of gallstone. Upper GI bleed and heme positive stools will be there, or Goyak positive stool, or FOBT positive. This may occur due to ulceration of the ampullary mass. Workup is again LFT. Total serum bilirubin will be elevated with the direct more than indirect. Both ALP and GGT are elevated. CA19-9 and CEA, these are the serum tumor markers for both periampullary carcinoma and CA head of the pancreas. CT scan also can demonstrate a mass in the duodenum. ERCP, you have to evaluate the ductal architecture further. UES guided biopsy also you can do. PET CT scan can detect metastasis elsewhere. Treatment: resectable tumor, you have to do Whipple's or pancreaticoduodenectomy. This should be followed by adjuvant chemotherapy. Unresectable tumors, only palliative bypass surgeries. Biliary obstruction, you can do biliary enteric bypass, cholecystojejunostomy. Endoscopic biliary stent also you can put, or radiographic transhepatic stent also you can put. This is the picture, endoscopic picture of Periampullary carcinoma. This is in the near the sphincter of OD. You are seeing a tumor. This is a EUS picture showing the same tumor here. The endoscopic ultrasound is the best investigation to precisely stage any GI tumors starting from esophagus up to the anus. This is the best investigation. So precisely we can stage the tumor, whether tumor is arising only from mucosa or submucosa or muscularis. Everything we will be knowing by doing an EUS or endoscopic ultrasound. Cholangiocarcinoma is a malignant tumor arising from intrahepatic or extrahepatic bile ducts. The extrahepatic is perihilar or distal duct. Perihilar is Klatskin tumor, which is very common. Risk factors are primary sclerosing cholangitis or liver flukes like Clonorchis sinensis. Coming to the clinical features, patient will have painful progressive jaundice because in CA head of the pancreas it is painless progressive jaundice. Here it is painful progressive jaundice. Because of slow narrowing of the duct, patient will have high color urine, pale color stool and itching. Nausea and vomiting will be there. Loss of weight and loss of appetite is there. There is palpable gallbladder because obstructive jaundice is not because of gallstone. Diagnostic workup again LFT, total serum bilirubin will be elevated with direct more than indirect. Both ALP and GGT are elevated. In prolonged obstruction, prothrombin time is elevated because of vitamin K malabsorption in these patients. Ultrasound shows biliary tract dilatation and larger hilar lesions. CT scan often demonstrate a mass. ERCP shows site of obstruction and this is for breast cytology and palliative stenting also can be done with ERCP. UES guided biopsy with FNAC also can be done in cholangiocarcinoma. PET CT scans can detect distant metastasis. Treatment, majority of these tumors are irresectable and complete surgical excision is not possible. So, only the following palliative treatment we can do. We can do ERCP and stenting or photodynamic therapy, radiation therapy, chemotherapy, radio frequency ablation, targeted therapy with futibatinib or pemigatinib. These are the chemotherapeutic agents you can use for targeted therapy in cholangiocarcinoma. So these are the various types. You see the perihilar variety or the Klatskin tumor. This is the Klatskin tumor. This is the commonest variety. And some they may have distal duct also may be involved, cholangiocarcinoma. This is an intrahepatic variety of cholangiocarcinoma where you can make out an intrahepatic mass. And this is the dilated intrahepatic biliary radicals. This is the perihilar or Klatskin tumor. Yeah, here. This tabular column is a quick recap where once again I have shown the various etiopathogenesis, clinical features, diagnosis and treatment about choledocholithiasis, biliary atresia, carcinoma head of the pancreas, periampullary carcinoma and cholangiocarcinoma. I request my viewers to pause the video and read all these points once again. So this will serve as a ready reckoner for you to clinch the correct diagnosis. So thank you very much for watching this video. If you think that these videos are really useful, kindly share them with your friends in your social media. Kindly click the bell button also to get notified regarding my latest uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye bye.